Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
And hello, David. And welcome to all of our listeners from wherever you listen to this podcast to episode 283. Today, we have a guest that we have super enjoyed having on our podcast before, Thai-An Truong, who is a level 5 certified team trainer and the star of the Oklahoma training. The team star of Oklahoma. I don't know how to say that. Welcome, Thai-An.
For correction, Thai-An is one of the stars of United States team training and treatment.
Absolutely.
Might as well up it up to the star of the universe.
I know we could do it in the Milky Way.
Thank you so much, Rhonda and Dr. Burns. Thank you for having me back as well.
Yeah, we're excited to have you and grateful that you can appear and illuminate us some more. I know your topic today is really an awesome one.
Yeah. So today we're going to be talking about the O of OCD. And we'll explain more about what that is. But first, I am going to read a very, very heartfelt email that a lovely listener sent to us. I've changed his name to protect his identity. But this is somebody who's been really impacted by Dr. Burns, your books and the podcasts. And we just want to read this as an example of what can happen for people through team therapy and through the books and podcasts and lots of hard work. And he wrote, "Dear Dr. Burns, it's been on my to-do list for years to write you a thank you note. And for some reason, today is the day. I want to say thank you for helping me turn my life around. In my school-going years, I felt very insecure socially, and I never came close to asking a girl or a woman out on a date. I eventually became quite depressed, although I was good at hiding it to those closest to me. Then one day I picked up your book, Feeling Good, and started reading the first couple chapters. Honestly, I don't think I got further than page 60 or such because it just clicked. It became incredibly obvious to me that I had to stop feeling sorry for myself, stop wallowing in self-pity, and start living. I realized that the only person who could do something to improve my situation was myself. As of that very moment, I stopped worrying about relationships and decided to just live my life the best I could. In the next 2 years, suddenly, as if a switch was flipped, different women started showing an interest in me. What an incredible change just from changing my mindset and being more confident. 1 year later, I met a lovely Chinese woman named Bai. We went on vacation together and fell in love. She has now been my wife for the past 10 years. We have an incredibly wonderful 6-year-old son, Jack, and we are enjoying our time as a family every day. All of this was kickstarted by reading those first couple chapters of your book many years ago. So once again, thank you, Dr. Burns. I wish you and your family an amazing life, and may your team CBT legacy continue to reach millions of people and improve their lives as it did mine. Have a wonderful day. Best regards, Tobias. P.S. Every time I need a boost, I watch your TEDx talk. It gets me every time."
Oh, that's great. Well, thank you for that very kind note. It just means so much to Rhonda and to me to hear that. Appreciate it very much. And I think that the man we're calling Tobias sent us a really awesome picture of himself that we can use in the show notes. And if that's right, make sure you take a look at the show notes. They always have tons of extra information at any rate, and this really, really handsome picture of Tobias.
Yeah.
So,
okay. What's the O of OCD about, Thai-An and David?
Okay.
Is it O or OH?
Maybe it's
probably OHCD. Yeah. So Rhonda wanted me to come on to talk about how I treat peer O, also known as peer obsessions, in OCD. And through a lot of the research, we actually see that peer O is actually a misnomer, that more often than not, people are still thinking of compulsions as those traditional behavioral compulsions that you can see, which includes like hand washing or checking. And so they think when people have obsessions without those behavioral rituals, then it's pure O. But what we see through the research is that people who talk about having pure O or just those mental obsessions also engage in mental rituals. So those are as equally powerful as the behavioral rituals in continuing to fuel the OCD.
Let me redirect just slightly. What you're saying is brilliant and awesome. Some of our listeners need to start at the very beginning, and maybe you can tell us, what is the O of OCD? What is the C of OCD? What is OCD? For us in the mental health field, it's obvious that everyone would know that, but in the general public, a lot of people wouldn't have that clear an idea of what it is.
Yeah, great point. So OCD stands for Obsessive Compulsive Disorder. O stands for obsessions, which are just scary thoughts or images that brings on distress. C are then compulsions that people engage in to try to decrease or neutralize the distress.
Right. And to give an example of that, I had a patient who had OCD, and his obsessions when he would drive home and park his car in the garage was that if he didn't shout dark, dark, dark out loud, something catastrophe would happen to his family. So his obsession was, my gosh, my family could get killed or ruined by some bizarre accident. And then his compulsion was to shout dark, dark, dark at the top of his lungs. And then he felt relief and went home. And it worked great for him until one night he closed a business deal, and he asked the fellow, invited him to come home for dinner just on the spur of the moment. And his wife said, that's fine. But then when they drove into the garage, he realized he had to shout dark, dark, dark at the top of his lungs. But he knew this would look bizarre for his colleague, so he suppressed it. And they went inside, and they were, sitting in the living room having a cocktail or something. And he became increasingly agitated, and he finally made an excuse that he had to check something in the garage because he was so anxious that he hadn't done his compulsion. And he went out and he shouted, dark, 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 and then went back inside, and he didn't realize that they could hear him. And when he got back inside, his guest said, well, what did you do that for? And he had to make up an explanation. He said, that we have rats, so I have to shout in the garage to scare them out every now and then. But at any rate, that's what OCD is, and I'll shut up now.
And it's interesting, the C often is kind of bizarre for people, and they have a sense of awareness of it being excessive or bizarre, but it feels very addictive. It feels like I can't stop this. I have to engage in it in order to feel better or in order to prevent that bad thing from happening.
I like how you frame it, that it's addictive. And I wonder if that's part of the framework of the treatment, if the treatment is similar to how one would treat habits and addictions.
Yeah, because if it's addictive, then you have to go through withdrawal.
Mm-hmm.
Mm-hmm. Yeah, exactly. When I treat the C part of OCD, I actually do use Dr. Burns's habits and addiction tools, for sure. I'm wondering at this point if it could be helpful to give examples of mental rituals, like when people look like they only have obsessions or pure O. instead of doing those behavioral compulsions, I'm wondering if it could be helpful to give some examples of the ritual.
Not really.
The mental rituals or
No, we don't want any examples.
Okay.
Yes, absolutely. Bring it to life for us.
So you all, if you relate to this, may recognize some of these mental rituals in yourself. So you may have obsessions, and common themes of obsessions could be, we often hear about contamination, but there's also aggressive obsessions where people feel like I'm going to harm someone else, like I'm going to hurt my child, I'm going to hurt my husband or kill him, or I'm just going to suddenly lose it and kill myself. So there are those aggressive obsessions, contamination. Common other obsessions are like sexual obsessions, where I've had clients who were obsessed that they were going to molest their children, never had a history of any kind of past out of the norm sexual behaviors, but it just felt really true for them in that moment. And of course, it violates your values. A lot of obsessions violates our values. That's why we engage in compulsions, to try to neutralize them or decrease the distress that they bring on. Other common ones I've seen are like religious obsessions, like I'm going to go to hell or my child's going to go to hell if we don't pray in this certain way. And even people who are atheists started to feel like I have to pray really rigorously throughout the day, so then we don't go to hell or my family doesn't get hurt in some way. And then the other one that's outlined in the Y box, which I'll share a little bit more, an assessment for OCD obsessions, are somatic obsessions, where they may be obsessed like, I have a bump on my head, could it be a tumor? Or I had a woman I worked with that was just obsessed that her organs were going to fall out. So it was...
I hate it when that happens.
And it was a normal childbirth experience, but after that, she just kept having this obsession that her organs were going to fall out. So there's some somatic or health concerns or illness obsessions as well. And then 90% of people with OCD actually report also having behavioral compulsions that we could see, whether they're checking or they're checking their blood pressure, checking the stove, hand washing, a variety of different things that we could look in and see. But those who have pure O are more likely to have the mental rituals, which examples could be, I've talked about already, like excessive prayer. They may be recalling events in detail. So I've had clients who would just review past memories like it was a movie to make sure they didn't kill anyone or run over someone, or that they didn't actually molest their child when they changed their diaper. So they'll just replay those memories over and over throughout the day. And it gets very time consuming when they're just lost in those mental rituals. I've had a client who had the religious obsession. Anything related to number 6 would be related to the devil. And so anytime they saw the number 6, they had to say 4 in their mind to just neutralize when they saw the number 6. So those are some examples of mental rituals. The most common one, though, is probably self-reassurance. So they really engage in the thoughts. They may say like, I'm okay, it's going to be fine, I'm actually a good person. So they'll really try to reassure themselves. But behavioral compulsions could also be seeking reassurance from loved ones, where they may ask their spouse or their parents or friends, like, do you think I'm a bad person? Do you think I would do that? Do you think I would kill myself? So I need you to be around me at all times, even though they actually, I could clearly remember a client who said, I don't want to die. Like that's not my plan. I would never leave my family. And at the same time, when I see my husband's gun or the knives, I think I could just snap one day and just kill myself. So that's more of the, it's kind of hard to distinguish sometimes from suicidal thoughts. But for a lot of them, they say it's ego dystonic, where it doesn't align with my values. It doesn't seem to align with what I want for my life right now. When we see people who are suicidal, it actually seems to align with their values, because they say things like, then I won't be a burden to my loved ones anymore. When I think of suicide, I actually sometimes find relief because it will give me relief from my suffering.
Right. I think a big distinction is that the OCD patient is terrified by these thoughts and impulses, whereas someone who is suicidal is attracted by the idea of either being dead or actually taking their life as the only relief from their suffering. But it can be scary for the therapist because you don't want to make a mistake. I had an OCD patient recently who was terrified of impulsively committing suicide, and I had to ask her to fantasize it, using exposure that you're going to be talking about, and it was terrifying to her, and I was a little frightened too. But it turned out to be really helpful to her. But, particularly because her fear was she'd just impulsively commit suicide, even though she didn't have any desire to commit suicide. She'll jump out a window or jump off a cliff or something of that nature. So the therapist can get sometimes frightened, just as the patient is often living in tremendous fear.
I imagine from what you've described, Thai-An and David, that it's very painful to have these obsessive thoughts because they're with you constantly, it seems. And, like you said, examples of mental compulsions of recalling events and constantly needing reassurance by yourself or from others. And the other things that you've described, it seems like it takes over one's life.
Oh, yeah. Like any addiction.
Yeah.
Absolutely. It is really painful. A lot of times it just really hurts my heart to connect with them and to see the torture that they're suffering in the OCD. And the more they try to engage with it, and anything that they try to do to make it better seems to make it worse. So a lot of times by the time they come to get help, they feel really hopeless, discouraged, terrified, tortured in this process, for sure.
Yeah. I had a patient who was concerned that he'd killed somebody. And he spent all kinds of time, like when he was driving, if he went over a bump, he would ask himself, was that a body I just ran over? And then he'd give in to the urge to pull the car over to the side of the road and go back and look and make sure. And he was a proctor in one of the dormitories at the university, and Parents' Day was coming up, and they had all this punch concentrate in the kitchen of the cafeteria and the basement of this massive 22-story dormitory. And he began to obsess that maybe he had put poison in it. And he gave in to the urge the night before this celebration with massive numbers of parents coming to visit. He went down and he threw all of that punch, into the sink. He destroyed all of it for fear that it might be contaminated with poison. And he was a brilliant student, but much of his life was spent, looking for somebody he'd killed or making sure he hadn't killed somebody or something of that nature. It was very, very overwhelming to him to be having to spend a high percentage of his time, like this, in agony and worry and self-doubt.
Yeah, I think one of the most valuable things people get back through OCD treatment is time. Just time
so
to
well
really
said,
engage
Thai-An.
with life. Yeah.
Time and joy and relief.
Yeah, absolutely. Time to engage in life the way that they want, according to their values. And it does bring it. It truly feels like what Dr. Burns talks about is that enlightenment after they heal from it. It's like I get it's a breath of fresh air, a new sense of engagement with life again. And it's been really moving work for me to see. I actually didn't seek out to treat OCD. I always found it to be kind of challenging. And as you all know, I started to specialize in postpartum women after my own struggle with postpartum depression and anxiety. And I wasn't aware at the time that postpartum women are actually 2.5 times more likely to develop OCD compared to the general public. And so that was when I started to encounter a lot of these cases of OCD and was feeling kind of baffled and stuck on how to move forward, as I was learning team at the time as well, right? But what you were saying, Rhonda, I wanted to emphasize that I think mental health therapists sometimes, when you talked about like just how much suffering and how painful it is, sometimes because of our fear of the ethical guidelines, we're more likely to jump to like, oh my gosh, this person's talking about harming their loved ones, we need to report them right away, without like a clear understanding of this person doesn't need to be hospitalized. And a lot of times that's really traumatizing for clients with OCD, because this professional is now confirming I am a risk to my loved ones, and that alone is a traumatizing experience.
That's so interesting. I've never heard of that, though. Have you heard of mental health professionals who've reported OCD patients? Because wow.
Yeah, definitely. I've seen that myself. I've had clients who said the previous therapist they went to had them hospitalized because they had either the obsession of suicide or the obsession that I'm going to molest my child, I'm going to harm my child, or I'm going to kill my husband.
Oh, awful. That's horrible.
Right? And so then they get hospitalized and reported. And so the cops come, put them in the back of their car like they're a criminal, and then they're brought to the hospital. And that alone is a really traumatizing experience. And through my training with exposure and response prevention, I took an intensive through the CTSA. The Center for Treatment and Study of Anxiety, which was founded by Dr. Edna Foa. She's a big writer on ERP. And they have also talked about a lot of cases.
Don't use abbreviations, because most of our audience are not mental health professionals.
You're right.
What's ERP now?
She's the big writer of using ERP, which is exposure and response prevention for the treatment of OCD. And they just do a lot of studies and work with clients with OCD. And one of their biggest disclaimers in the training on day one of the intensive was, do a thorough assessment and don't overreact, because a lot of times if they're terrified that they're going to harm their loved ones, it shows it's not aligning with their values, and they're not a risk. They're not a risk of harm to themselves or others.
Yeah. Just as an aside, to give Edna a plug, I knew her in Philadelphia when I had my clinic there, and she is tremendous. She's just a fantastic researcher integrating clinical work with research, which is so important.
Mm-hmm. Oh, and that's so cool that you knew her.
Yeah, she's really a neat lady, and I learned a lot from her too. Although I just had a few interactions with her, I have a tremendous esteem for her, and she's the one who, more than anyone else, has probably put exposure and response prevention on the map. Mm-hmm. We don't agree on everything, and certainly exposure and response prevention are not a treatment for OCD, but they are important tools in the treatment for OCD. And she has shown through her research, it's probably the most documented single tool in all of the mental health arena of ERP for OCD.
Yeah, I absolutely agree with you, Dr. Burns. While ERP, exposure and response prevention, is claimed as the gold standard treatment for OCD, I think in team we see it as a really important method, but it is a method, and it's important to integrate the other treatment models as well to truly heal OCD at a deeper level, because actually through the training, there were some cases that I thought they really could use the hidden emotion and could probably find more success, like clients who they labeled as resistant to ERP, and didn't want to get better. I'm wondering if like some motivational tools could have been helpful.
Oh, absolutely.
Hidden emotion instead of continuing to do exposure. I'm excited to share about a case that I had that had really intense compulsions and was completely cured by just the hidden emotion.
Oh, cool. Tell us about that. We'd love to hear about cases, and our audience will find it helpful too.
Yeah, absolutely. Rhonda wanted me to lay out like the treatment process. So I'm wondering, should we start there? Or do you want me to go ahead and jump
In
into
any way you want to do it.
example?
If you go into the treatment process, just keep in mind that the majority of our listeners aren't shrinks. So, it has to be at a kind of popular level, so everyone can understand it. But yeah, all the things you have to say are great.
Yeah, and while this isn't medical advice or therapeutic advice, I think this could also just give awareness to the general public of tools or things that they could do with their own therapist that could be helpful if they relate to some of these themes of obsessions and engaging in compulsions to help themselves feel better. Did you have a preference, Rhonda, for me to start from the beginning of how I approach the treatment process, or go ahead and give an example and then go in?
I don't have a preference. I think it's really fun to bring it to life with a treatment example, and then maybe you could go through the analysis of what you did with your patient and the outline of what you do in general.
Yeah, okay, great. So the person that I'm thinking of came to me she had just said, I just have really high anxiety and I'm really scared. At night, one of my greatest fears is that my baby will electrocute herself. And she says, I know that's irrational because my baby's in his crib. He's not even crawling around yet at like 6 or 7 months or so at the time. But her compulsion was she had to go around the room and check all of the electrical outlets. She would check any cords that were in the room to make sure there wasn't any breaks along the cords. And so when I heard that, I was like, oh my goodness, I'm assessing her compulsions. And she says it would take 1.5 hours to 2 hours every night before she would go to bed. She would have to do that. Make sure there's no breaks, there's nothing strange with the outlets. And so once she's confirmed with more certainty that her baby's not going to electrocute himself, then she could go to bed. So in my mind, I'm thinking like, oh my gosh, this is a pretty intense case. We're going to have to do a lot of exposure and response prevention so she doesn't engage in that process. And so when we start the treatment process, I do really like the Y box, which is the Yale-Brown Obsessive Compulsive Assessment. It is not diagnostic. If you want a diagnostic tool, I just want to give a plug for Dr. Burns's easy diagnostic tool that could really allow us to weed out a lot of the anxiety disorders and allow us to diagnose OCD pretty quickly. It takes them 30 to 35 minutes to complete that. So I would recommend that assessment so you can assess for OCD. And then the Y box would just allow us to really sort out what are their types of obsessions, what compulsions do they engage in, because ultimately we see that the compulsions is the fuel to the OCD. The compulsions is the food that continues to feed the obsessive compulsive disorder. And so we want to weed out what are all of the compulsions that they engage in so we could do effective response prevention for all of them. And the obsessions, while we have a lot of different subtypes that people have categorized, that is also, it could lead to the misunderstanding that you just have one subtype. And what we find in the research is most people with OCD have multiple types of obsessions. So I may even have a client, one week they come in and they're afraid that they're a pedophile. The next week they're afraid that they're going to kill their husband. And then the next week they're afraid that they're going to go to hell. So it could be religious themes, harm themes, all in one person that could bounce around from week to week. And so through the Y box, they want us to see what are current obsessions that come up for this person, but also obsessions that they've had 30 days, beyond 30 days in the past as well, because it's not uncommon during your treatment that other obsessions from the past can come. So just then we could have awareness. And then when we create a fear hierarchy, we could have all of those themes and exposures that could be effective for all of those themes.
Can I stop you for just a minute, because our audience doesn't know what a fear hierarchy is, and that's such an important thing that you mentioned. Can you just tell them kind of what a fear hierarchy is?
Yeah, definitely. So after I do the why box to understand what are their types of obsessions, what are the types of compulsions, and also avoidance behaviors, we get to the point where we will create a fear hierarchy where we just look at what are things, exposure exercises that you can face that brings on anxiety, that can ultimately then allow you to really relearn. So I'm going to face this thing that I've been avoiding, and then I want to make sure I do response prevention. I don't engage in the compulsion at that time. Then that's when the new learning takes place. So an example on the fear hierarchy for the woman who's afraid her child would get electrocuted would be, I'll just expose myself by even like holding the cord or something that isn't completely perfect, or leaving that cord next to her child, like just unplugged, right? So that's just an example. Like if the cord was near my child, I'd be terrified. And we're having them step outside of their comfort zone, but not outside of their safety zone. So I wouldn't have like it be plugged in and then have a break where her child could actually electrocute himself. It would just be an example of like, this would be a cord that's not plugged in, but it has a break, and that could bring up their anxiety to 70 to 80%.
So you'd have a hierarchy from 0 to 10 on increasingly scary things that you would agree to gradually expose yourself to, going up the hierarchy, starting with the least threatening. And then once you've overcome your fear of that and no longer frightens you, go up to the next thing on your hierarchy until you've gone all the way up to the most fearful thing. Is that the idea?
Yeah, you articulated that a lot better than I did, Dr. Burns. That's exactly what they do. And do you
personally? I was going to ask if in your work, do you personally prefer a fear hierarchy, gradual exposure, or flooding, where you just go to 10 right at the beginning and get it over with all at once? Or do you sometimes use one approach and sometimes use the other approach?
Yeah, I like your perspective that you've shared with us, that both are effective. And what I've really liked is to just ask the client. So I would share with them, you could do this gradually. It does take longer when you do gradual exposure, where we start at the 40% fear item and then move on up. Or we could actually do flooding, where we jump right into that fear exposure exercise that brings you to 90 to 100. And that will actually be more terrifying at first, but it does help healing more quickly. Both are effective. One just takes longer than the other. One is a little bit scarier to tolerate than the other. Which would you like? More often than not, I had people choose gradual exposure, probably the majority of the time. But sometimes I've had someone who said, I want to get through this quickly. I want to get over it, and they'll choose flooding. Cool. So I think when it was client guided, there's more of a buy-in. But I know you have a style too, Dr. Burns, that's very effective, where you just tell them, let's just do that. Do that thing that you're most afraid of, and you're right there with them. And it sounds like that's been really effective for you as well.
Yeah, but both it's good to have access to both kinds of tools because, one might be much more or much less appealing to a particular patient. Do you find that some therapists that I know you do a lot of training, have an important conference coming up that we'll mention at the end of the podcast for Oklahoma mental health professionals, but do you find that some of them, fight against using exposure with these or with any anxious patient?
I think most therapists feel terrified of exposure as well, myself included. Like initially doing this, I'm like, I'm going to have my client imagine molesting her child. Like that's her worst fear. So I think for a lot of us, it feels really scary. It feels like, am I doing something that's helpful, or am I torturing this client?
Right, and exactly.
Yeah, it took courage, I think, to move forward with that. And only when I started to see a lot of powerful results through exposure that I'm just sold. It's important. It's crucial to move forward.
I love what you're saying.
Me too.
Yeah, for sure.
So go back to your client, Thai-An.
Okay. Yeah. So
does she create the fear hierarchy as homework, or do you do that together?
We didn't start on that yet, actually, because I often really like to go towards the hidden emotion first.
Okay, tell us about that.
And so after doing the assessments, I just share with her some psychoeducation about the nature of intrusive thoughts. And the more we try to engage with them or reassure them or respond to them with compulsions, the stronger they actually get. And I share with her then that one treatment model, we use 4 different treatment models for the treatment of any form of anxiety. But a crucial one that I've often seen be effective for clients with OCD, not always, so don't hang on to any one tool, but oftentimes I've seen it to be a crucial healing tool, is called the hidden emotion. And this just means at the moment when my anxiety comes about, whether it's my obsessions, my compulsions, panic attacks, over worrying, anything else, there may actually be something deeper that's bothering me. But because I'm a nice person, I don't want to give voice to it. I don't want to address it. And so then...
In other words, I'm not supposed to have these feelings of anger or wanting something, like wanting a different kind of job or not wanting my major in college, that because the OCD patients and all anxious patients tend to be the nicest people in the world, they're often trying to be overly nice and suppressing certain kinds of feelings. Is that what you're saying?
Exactly. Yeah. And I share with them that it's a hidden emotion or a hidden desire. And oftentimes the emotion is anger, but not always. It's an emotion they think they shouldn't have. And then the desire is just something I really want for my life, but I don't think I should either, because I want to be nice, or I shouldn't, like a mom who's I should stay at home with my child instead of wanting a career or something like that.
And I should be happy with that. I shouldn't have any resentment about staying at home with my child, because mothers are supposed to, love every little ounce of mothering.
Yeah, exactly. All of these shoulds, I think, plays a part in the hidden emotion. So I just shared that with her. I also share with her about the motivational tools that we'll be using, some cognitive tools that we'll be using, because she was very discouraged that she could stop this. So I address self-doubt, discouragement, hopelessness. And then I share with her we'll also likely need to engage in exposure, where she stops checking these electrical cords in order to get healing. She was all in with all of that, but was really intrigued by the hidden emotion, because she said, "You're sharing with me something I've never heard before. And I've been to a couple of therapists, and they often give me like breathing techniques and ways to calm myself when I'm anxious, but I've never heard of the hidden emotion." Yeah. And I was like the 3rd or 4th therapist that she's gone to help her with this. And I also pointed out to her, I noticed you're also just a really kind person. And through our intake, it seemed like she's taking care of everything with the baby, right? So she didn't talk about anger with her husband, but she says, "I'm just overwhelmed in the morning." Her husband had some health issues, so he truly needed more sleep than most people due to the severity of his health issues. But he's gotten to the space where he really could do more in the morning and in the afternoon. So I just gave her the hidden emotion to think about, because I pointed out, like, it seems like you are a really kind person. And I'm wondering if there's something right now that's bothering you, possibly around your husband or even needing more help. I'm just throwing out theories here. I could absolutely be wrong, but it may be helpful for you to think about what it could be that's bothering you, that you're not addressing maybe late at night when your obsessions are especially strong, right? And so she just thought about it. At first she said, I'm not too sure, but there may be something there, because I often don't share when I'm upset with people. That's been my whole life. I've been taught to just be nice. That's how my family is. And it's interesting because other therapists had even talked about, like, your compulsions are so extreme. Have you been traumatized? Have you, did your parents do anything to you, et cetera? And she said, I've honestly had a really great upbringing. So when therapists try to dig down into what trauma happened to me, that I'm engaging in these compulsions, that doesn't really align. But her family is actually a really nice group of people. And so they have taught her to forgive people. Don't share your anger. Let's just move forward with life and be kind. So she came back the following week and said, I think I know what it is that's bothering me. I'm really resentful towards my husband, and I don't think I should be, because he's been through so much and he's had all of these health issues that's been really scary for us. But I think he could do a lot more. Like, I'm doing all of the morning care for the baby, taking the baby to daycare. At night, I'm also, cooking and cleaning, and he helps some with some of that process, but then I'm completely drained. And then I'm doing bath time, I'm reading stories, I'm doing everything at night. And so it's almost like the checking of the courts was her way of avoiding intimacy with him too. Like, I don't want to get to bed earlier with you. I'm not connecting with you right now. I'm upset that you're not stepping up more, but she's never verbalized that. So this is the piece that with the hidden emotion that I think is sometimes exposure therapy in and of itself. Because as Jill Levitt points out, the hidden emotion is a two-step process. The first is insight, and the second is action. The insight helps you explore, what is it that's bothering me that I'm not addressing? And once you find out what that is, you have to do something about it. That's the action part before you can get better. But what I've seen is between the space of insight and action, there's a lot of fear. That's why they haven't revealed that hidden emotion or talked about the thing that's bothering them. So I actually use Dr. Burns's motivational work in the hidden emotion, where I talk about, first, can you tell me 0 to 100, how motivated are you to share your anger and resentment with your husband? And she said, this sounds important. I think I should move forward with this if this could help me with my anxiety. So her motivation was about 70%. And then I would share with her, at the same time, I think there's been a good reason as to why you've held in your anger and you haven't talked about it. Let's first look at all of the good reasons to not share your anger, all of the good reasons to continue to hide your emotions and what's bothering you.
Let me stop you for just a second, because it's so important what you're saying. It's the opposite of what the normal therapist would do, would be to push something else called assertiveness training, where you're telling people what to do to have a better life. And here we're going in the opposite direction of giving them all the good reasons not to do the thing that would be healing and curative for them. So that's to bring the resistance to conscious awareness, and it's way more effective than trying to sell people on what we think they should be doing.
Yeah, because I'm not pushing her to engage in that action right now so then she can get better and overcome her anxiety. I'm trying to align with the parts of her that hasn't wanted to share her anger, probably for a good reason. And she came up with some really beautiful things like, I haven't shared my anger because I love him. I want to protect him. I don't want to hurt his feelings because he's also a really sensitive, kind person. This has been my way of sacrificing for my loved ones. That's important to me, that I protect him and his health. And so once she uncovered all of those good reasons to not move forward with expressing her anger, I re-rated motivation to change and to move forward with this conversation. And she said, it's actually about at 40% now. I don't know if I want to move forward with this. I could see why I haven't. And then I jumped in with something Dr. Burns all of his tools are brilliant, but I really love when you see the effectiveness of it. And so I just continued to align with the resistance. And I shared with her, or my wording was, so why should we move forward with having this conversation? Well, I think there's a key piece here. So dangling the carrot a little bit on having these conversations could really help you with your anxiety. I'm also seeing a lot of good reasons to not move forward with having this conversation with your husband. Why would you want to move forward with sharing your anger with him when he could also be hurt by it? And, we just go through one thing at a time. And she said, I'm hurting right now. And I think because he loves me, he would want to know that. And I said, okay, that makes a lot of sense. But at the same time, he could get angry with you if you share that you need him to step up a little bit more. And she said, well, if I look at my past, that's not true. Like every time I've had conversations with him, he's been understanding. Maybe he was hurt, but then he actually aligns with me. He's been a really good partner. I just haven't had a voice, so he doesn't know. And so through this process, it's like she's convincing me and herself that she wants to have this conversation. And by the time we finish that tool with voicing the resistance, also known as externalization of voices or of resistance, I'm sorry, I don't call it externalization of resistance because I think it gets confusing with externalization of voices. But once I voiced the resistance, by the end of that, she said, I need to have this conversation. I'm at like a 95% readiness. And it was mind-blowing to me. She came back the next week and she told me, I have no more compulsions. We've had the conversation. Her husband even came up with a plan, like of checklists of things he could do in the morning and at night to help her. It just became a beautiful partnership. He said, I didn't know. I didn't know. And sometimes you're such a strong person. I thought sometimes it's like insulting to step in because I know you talk about like, I want to do this. I want to take care of our baby. I can do this on my own. He didn't want her to think like she was weak or something. So he didn't step in.
Yeah.
Because she had that belief. She said, like, I should be able to do all of this on my own as a strong woman. I don't need my husband's help. So he was responding in that way because of that belief that she carried. But it was so incredible to me that literally 0 compulsions after that conversation. No more checking the electrical cords, no more looking at the outlets. And my thought was, if I did ERP with her, I wonder how far that would go if I continue to have her be exposed to electrical cords and thoughts of her child being electrocuted. That would have probably been disastrous.
Yeah, but probably would have been ineffective because there was part of her that was, something that hadn't been addressed. There's a take-home message, and plus one other point I want to make about the hidden emotion model. But for listeners, if you're struggling with any form of anxiety, even if you're not a mental health professional, but this is one of the powerful, curative techniques. You can read about it in my book, When Panic Attacks. There's a nice section on the hidden emotion model. And what it really means is you're probably an exceptionally nice person. And if you have any kind of anxiety, PTSD, OCD, panic attacks, phobias, constant worrying, there's a very high likelihood that there's something you're upset about in the here and now, not something buried in your past, something buried in your present that you're not expressing due to your niceness. And if you can bring that to conscious awareness and then act on it, express the feeling, solve the problem, in many cases, the anxiety, as you saw, will completely disappear. The OCD will completely disappear. And there's an important hint that you didn't mention as to how to figure out what it is that's bugging you. And part of it is that the OCD, anxiety is like poetry. It's your subconscious mind in symbolic form giving you a hint at what's bugging you. And the nature of the anxiety always contains the solution. So in this case, you would ask yourself, here's a woman who's worried that she's going to electrocute her child. And she spends a lot of time thinking about electrocution of her child. What would be the emotion that would make her want to electrocute her child? Why is she so worried that she's going to have an electrical cord that's going to, kill her child? What would you say, Thai-An or Rhonda?
Mm-hmm. The emotion of that would drive you wanting to electrocute someone?
Your child.
Are you thinking of your child? Are you thinking of like that would be like anger or resentment or something of how much of a burden this is all on?
Exactly. Her subconscious mind is telling her this is a big burden to you and you want to get rid of this child on some level, but she can't bring that to conscious awareness either, because you're not supposed to be angry toward your child. You're not supposed to be angry toward your husband. And you're not supposed to be resentful. As a woman, you're supposed to do duty, and please everyone and not get upset about it. And so it's telling you something really important. Your symptoms are telling you something really important. And that's why I think Edna's work and people who are into exposure are doing something fantastic for the field of mental health and for society, because those are important tools. But at the same time, they're missing the boat, because there's many tools that can be powerfully healing for people with any of the anxiety disorders, including OCD. So
can
anyway,
can I see one observation, Thai-An? Your description of how you went through the motivational model is so clear and specific. I think anyone could have their therapist listen to this and help follow along. What I loved was how you asked in the very beginning, before you did anything, on a scale of 0 to 10, how motivated are you? She said 60. And then you asked her all the good reasons not to share your anger, and she listed them. And you asked her again, how motivated are you? And she went down to 40. And then after going through the, challenging her resistance, what we call externalization of resistance, she went back up to 100.
95.
95. And, I think if you hadn't asked her, how motivated are you at these different steps? Or if you had been stopped by the numbers out of like, oh my gosh, well, now you moved down, maybe I should back off. But you kept going. You kept going, and her fluidity was just part of the process. And then you could see the level of success you had with her when you completed the externalization of resistance. I think that was really neat.
Psychotherapy is an art form. It's not like Lincoln Logs that we used to play with as a kid, where you build a cabin with these, sticks that come in a box. It's an art form. It's subtle. It involves paradox. It involves working with the human being. And you just gave a beautiful example of how you skillfully integrated the paradoxical piece of team therapy with the hidden emotion piece to bring a beautiful, rapid, dramatic changes for your patient in a way that wasn't just focused on controlling symptoms or eliminating symptoms, but enriching someone's life. Now, let's assume that there are some therapists listening to this program and they say, wow, this Thai-An is really a kick-ass teacher and therapist. I'd love to learn from her. I know, we'll put in the show notes your contact information for your clinical practice or for your online training classes that are excellent and highly recommended. But you have this symposium coming up at the March 28th to April 1st or something like that. And suppose there's some Oklahoma therapists who would like to attend this Team CBT symposium that you're offering. To tell us what that's going to be like, and what they should do if they'd like to attend.
Well, as you all know, I'm super passionate about Team CBT and have seen what Dr. Burns has created is going to change the world. And so it lit a fire in me to put on the first Team CBT conference in Oklahoma, and it's going to be held on March the 30th to April 1st. And people can earn all of their 20 CEUs. It's approved for psychologists, LPCs, LMFTs, and LADCs. To earn all 20 of your CEUs, including ethics. And for 3 days of fun learning with Team CBT, I'm really excited about it. And if people are interested in registering and joining, right now we have 54 therapists who will learn more about team than we had before in the past. So I'm super grateful for that. If you'd like to join the 54 therapists at this time for 3 fun days of learning really powerful, life-changing tools, not just for your clients, but for yourself. I truly believe that clinicians who dive into Team CBT get transformation for your own personal life as well. You could visit teamcbttraining.com/conference. Again, that's team, teamcbttraining.com/conference. And you'll be able to get all of the information about that training and be able to register and pay through there as well.
Thai-An, will that be in person or online?
Yes, it is in person. Mm-hmm.
Fantastic. More power to you. And I hope this is the first annual conference of something that grows and evolves, continues to evolve. I know you could go on for another hour or so, but we're kind of at the end of our hour here, and you've given us plenty to think about. Are there any other points that you'd like to make at the end? And then if there are, go ahead. And then at the end, Rhonda has some really amazing and important things to say.
Okay. Yeah, unfortunately, we've only gone through half of the material that I was planning to share. But one piece that could be important is also using the habits and addiction tools for the compulsions. So what we've done with the motivational work for the hidden emotion, I also do with the compulsions, because right now it's serving a powerful purpose. And so we first can do the triple paradox, and clients, general public, can do this for themselves too. What are the benefits of continuing to engage in your compulsions? And list out all of them, whether you're compulsively Googling information, seeking reassurance, checking, hand washing. List out all of your compulsions, but then list out what are the benefits of those? What values does it connect with? And what are the costs of letting those go? Because initially it's going to feel like you've lost this friend that's given you a lot of comfort every time you've engaged with it. And then from there, I do the same thing with rating motivation to let go of your compulsions. We know that's the food for your OCD, but you're going to want to continue to engage in it. And chance of relapse is 100%. Right. And relapse doesn't mean like I will necessarily engage in the compulsions, although that's likely, but the temptation to engage in compulsions, again, will be at 100%. So where's your motivation to letting that go? We can do the triple paradox to see the benefits that you get from the compulsions, rate motivation to change again. And then we could also do voicing the resistance, considering that Googling gives you immediate relief. Why would you want to let this go? Why would you want to change it? And I want them to have a strong voice about why they want to change. Well, I know Googling gives me immediate relief, but it's making my OCD worse. And I don't want to continue to live life this way. Sure. And whatever statement that they make, I want them to write that down. And I call that a motivation script, where every response that they have as to why they want to let go of compulsions, they'll have it in writing. And they could record it and listen to it, but at least read it every single day, because motivation will ebb and flow. And what I've seen is if they have their wording in response to why they want to change and read it in the morning, at night, anytime they need it, it really boosts motivation to keep going.
Right. And just a couple things to amplify that. If any listeners want to use that triple paradox, I'm going to tell you again right what it is right now to make it a little clearer. But if you want to try it, you can go to my website, and at the bottom of the homepage, there's a free download where you can get 2 unpublished chapters from my recent book on habits and addictions, including the triple paradox and exactly how to use it and so forth. But for habits and addictions, for OCD, there's 3 vertical columns. And they're all paradoxical. The first would be list all the benefits of your OCD. How does it help you? What's terrific about it? The middle column is what would be sucky about giving up your OCD? And then the third column is what does your OCD show about you and your core values as a human being that's positive and awesome? So it's triply doing exactly the opposite thing that most therapists would do. And it can have surprising liberating effects, bringing all your resistance to conscious awareness, and suddenly, whoosh, you find motivation that you didn't think you had. And one other thing on habits and addictions with regard to compulsions, I often tell my patients that when you stop doing your compulsions, it's like withdrawing from heroin or alcohol or anything that you're trying to withdraw from. Initially, you're going to get worse. When you don't give in to those compulsions to wash your hands over and over again, you're going to freak out because you're going to think, oh my gosh, I'll get contaminated. My family will get contaminated. They'll die of leukemia. And if you keep resisting that compulsion, you'll have several days of intense worse anxiety. But if, like with any addiction, if you wait it out, then suddenly the urge for those compulsions will diminish and pretty quickly disappear entirely. So thank you.
That was beautiful. So here's my summary.
Okay.
Neither of the two of you said anything about medication. And I had a childhood friend as I was growing up, my brother's age, a little bit older than me, who eventually developed OCD and was put on I don't know what it was, but it was such a severe medication that it completely kind of deadened him. And he was like, oh yeah, I'm so grateful for this med, because now I don't have this obsession. But it never completely went away. And the medication was, it seemed to me, its own problem. And I love that the processes that you've described can be free of medication and, really lead to a complete elimination, and, as we always try to, an enlightened state of their lives.
That's so true. And I've never treated an OCD patient with any kind of medication. In fact, if they come to me for treatment, I won't accept them for treatment or any form of anxiety unless they agree to go off of the medications that they're taking. And if they want to just keep taking meds, and benzos are highly addictive and ineffective. And, if we had a medication that was a cure for OCD, I'd be the first to promote it. But the drugs are not effective. But the new psychotherapy techniques can be, as to quote you, Thai-An, mind-blowingly effective. Mm-hmm. So thank you all for tuning in today. Thank you, Thai-An, for gracing us with your brilliance and your artistry. And your heart. It's very, very inspiring. And we all, I think, learned a lot today, too.
Absolutely.
Thank you so much for having me. And I love connecting with the both of you. So it's always a joy. Thank you so much.
Good luck with your conference. I hope it's a lot of fun for everybody.
Thank you. I'm so excited about it. I hope so, too.
Okay, see you later. Till next time.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.